Okay, so we're going to go into non-androgenic compounds. So first we're going to cover the considerations and risk involved in female PD users. So when introducing the topic of performance or physique enhancing drugs for females, we must remember that females are androgen sensitive in nature, meaning that their ability to metabolize androgens is far less than males. And when assessing the risks, the chances of experiencing adverse side effects is largely due to the duration of exposure to supraphysiological ranges as opposed to the total amount or type of androgen, although both need to be considered. Supraphysiological is simply pertaining to that greater than what is naturally seen in the body or physiological ranges. The most obvious risk comes from virilization, so that's going to be growth of an Adam's apple, facial hair, growth of pubic hair, enlargement of facial features, enlargement of the clitoris, deepening of the voice, androgenic alopecia, which is the hair falling out and most commonly seen in high-stress environments. Hello, prep clients. Androgenic orientated acne. It's important to remember too that some of these are irreversible, and the most concerning one is probably the least obvious, and that's a decline of the female's reproductive system, with the suppression of gonadotropins, meaning FSH levels drop, LH levels drop, and as a result, E2 drops. Remember that E2 is needed for healthy skin, hair, brain, and kidney function, bone health, and vaginal protection. Over years, this will lead to an accumulation of health damage to organ systems and infertility. Because of these risks, it's important to understand that the first goal of a performance-enhancing drug education for female competitors is risk mitigation. This is coined the safer use model. Similar to males, the safer use model underscores the use of compounds that have not been tested in human clinical data. These are drugs that have been used to treat certain conditions such as cancer research, various endocrine issues, and burn victims. We have androgenic compounds, so they work on the androgen receptor. Non-androgenic compounds, so your lipolytics, which drive fat loss and fatty acid oxidation, and ancillaries, which is essentially your health medication. Non-androgenic and ancillary compounds alone will bring about very appreciable results in a female. These will be the first exposure element, and we should deploy drugs from least aggressive to most assertive basis. Essentially, if we have more of what allows a female to recover, drive training performance, improve health outcomes, and improve nutrient partitioning, then she has a rather great advantage with very low risk. So the first compound we're going to discuss is metformin. Metformin is a synthetic derivative of a plant known as galligan. I think that's how you say it. And what makes it so unique is that it hasn't been designed for one single mechanism. And this diversity is what allows it to be used in many different scenarios. Metformin acts on the liver to improve blood glucose levels by reducing hepatic glucose output and inhibiting hepatic lipogenesis and gluconeogenesis. It also acts on the gut to increase glucose utilization, meaning it promotes fat oxidation by inhibiting fat synthesis, thus reducing the amount of fat in the liver and improving insulin sensitivity. Metformin also has actions on the gut microbiome by changing the concentration of certain bacteria and has potential antimicrobial effects. When we see individuals in a controlled energy deficit, metformin does have benefits in improving the rate of weight loss also. It's important to understand though that it doesn't drive weight loss by simply just administering the drug, and if not moderated by energy balance, meaning there must be a hypocaloric environment available. The weight loss may be a result of appetite reduction. Some studies have shown that individuals who take metformin have a lower energy intake, and this may be through increasing lactate production and leptin receptor expression and decreasing leptin resistance, resulting in reduced food consumption. Metformin also has benefits to longevity, with multiple rodent studies showing improved lifespan and health span and a decreased rate of cancer development. So in summary, metformin has a number of benefits, including improving insulin sensitivity, lowering LDL, increasing HDL, increasing fatty acid oxidation, decreasing inflammatory markers and oxidative stress, and improving gut health. The misconception with metformin is when it comes to its perceived interference with hypertrophy due to the activation of AMPK. AMPK interferes with the ability to activate mTOR, and mTOR is involved in the regulation of skeletal muscle mass. However, none of the subunits involved in this process are activated by metformin. Nevertheless, with metformin being such a strong antioxidant, it may interfere with some of the oxidative stress needed to elicit hypertrophy, and dosages and timing of metformin should both be of consideration. Currently, metformin is still only used for the treatment of type 2 diabetes and yet to move into the treatment of obesity or metabolic diseases. Doses of metformin typically start at 250 milligrams daily and are titrated up as needed, with the ceiling dose being around 1,500 to 2,000 milligrams a day. In enhanced females, the primary advantage is going to be seen from improved glucose uptake, improved recovery, and lipolytic benefits with no virilization side effects. So the dosing for females is going to be between 250 and 1,500 milligrams a day, and the possible side effects to be aware of are diarrhea, fluctuance, bloating, and decreased CMB12 levels. And now we'll move on to telmisartan. So PD users on average have higher blood pressure than natty competitors, and this could be due to higher hematocrit levels, so that's a percentage of red blood cells in the blood, increased water retention, stiffening of the arterial wall, and increased activation of the sympathetic nervous system from things like clenbuterol and yohimbine. When it comes to drug intervention for addressing hypertension, telmisartan tends to be the medication of choice. This is an angiotensin II receptor blocker, or ARB, used to treat high blood pressure, heart failure, and diabetic kidney disease. Renin-angiotensin-aldosterone system, which is RAAS activation, causes inflammation, vasoconstriction, thrombosis, fibrosis, and superoxide formation, which can result in cardiovascular disease. Telmisartan blocks the receptor for angiotensin. It also acts in preventing left ventricular hypertrophy, which is the thickening of the wall of the heart's main pumping chamber. Telmisartan has many other benefits besides regulating blood pressure, such as being renal protective, increasing IGF-1, reducing oxidative stress, and increasing insulin sensitivity, and decreasing white adipose tissue. In female application, this is going to be another pathway that we can utilize to again see rather appreciable results in terms of improving glucose utilization in skeletal muscle, increasing aerobic capacity, increasing fatty acid oxidation, reducing liver fat, and so on, without being exposed to androgens and further avoiding possible virilization and side effects. The dosing for performance athletes is going to be 0.2 milligrams per kilogram. Next, we'll move on to injectable L-carnitine. This is an amino acid indicated for carnitine deficiency syndrome. Carnitine transports fatty acid across mitochondrial membrane to the site for better oxidation or fat burning by increasing the use of fat for fuel. Muscle glycogen is spared and metabolic rate increases, resulting in greater insulin sensitivity. It also increases androgen receptor upregulation and prevents androgen receptor degradation from training. Further, it increases nitrogen oxide production, helping the body dilate and constrict blood vessels. This can improve your blood pressure and therefore your heart health, and increase training performance and decrease exercise-induced muscle damage. All of the above essentially allows for leaner gains at the off-season, and in contest prep allows the body to burn more body fat and for muscles to stay fuller through glycogen retention. The reason that one would opt for injectable over oral is that the oral is approximately 20% bioavailable, whereas the intramuscular or subcutaneous injections are 100% bioavailable. Potential side effects include hyperinsulinemia augments carnitine uptake in muscle in oral L-carnitine, and it could lower T3, T4 in hypothyroidism patients. Dosing for performance athletes is typically 200 milligrams per day. Now we move on to growth hormone. This is what we term a sexually dimorphic compound, meaning that it acts differently in females to males. Females tend to see a greater benefit from a lipolytic perspective than hypertrophy perspective. This is because females are 3 times less responsive to HGH to IGF-1 conversion compared to males. So let's dive into growth hormone's effect on carbohydrates, lipids, and protein metabolism. At adipose tissue, we see an increase in lipolysis, reduction in glucose uptake, reduction in liponeogenesis, and a reduction in re-esterification of free fatty acids, overall resulting in reduction in body fat mass. At skeletal muscle, we see reduction in glucose uptake, increased lipoprotein lipase activity, resulting in an increase in beta oxidation. And at the liver, we see an increase in very low density lipoprotein secretion, resulting in an increase in production and uptake of IDL, HDL, and LDL lipoproteins. IGF-1 is taking the energy substrate made available by GH and using it for growth and repair, and therefore IGF-1 carries most of the growth promoting aspects. When used in combination with androgens, we see an increased synergy to promote increase in lean body mass than that seen with just using GH alone. This is because AAs increase satellite cell numbers, providing more raw material for GH to act on. We see the indirect benefits of growth hormone as a potent stimulator of collagen synthesis in tendons and skeletal muscle, increased decrogene expression, and that is the protein in skeletal muscle, and its main role is in growth and repair. Someone might then pose a question of what is the maximum dose for fat loss? Luckily, we have clinical data that demonstrates the ceiling dose for topping out free fatty acid mobilization. As with most things in bodybuilding or fitness, more isn't necessarily better. There are counter-regulatory mechanisms in place to prevent additional lipolysis from occurring at above a certain threshold. The study measures the effects of no growth hormone at all and 1 microgram per kilogram, 3 micrograms per kilogram, and 6 micrograms per kilogram of growth hormone on free fatty acid mobilization. From the study, we can see that the dose-dependent increase in free fatty acid mobilization from no growth hormone up to 3 micrograms per kilogram. However, no additional effect is seen from doubling that dose to 6 micrograms per kilogram. Therefore, if body weight is 100 kilograms, that means that per dose of growth hormone, 300 micrograms would be the ceiling dose to maximize the lipolytic effect. 1000 micrograms equals 3 IU, so 300 micrograms would be about 1 unit. Now, this study was measured using intravenous administration, which I would recommend to absolutely no one, as it would definitely be contraindicated without the supervision of an administration by a registered medical provider. The risk of infection is bad enough, and the repeat exposure to that bodybuilders see, let alone the venous infection, which is just devastating. We see a comparative bioavailability of 70% with sub-Q compared to IV. Accounting for the lesser bioavailability of a sub-Q administration, we are left with 1.3 units sub-Q dose. All means that the maximum effective dose for growth hormone for fat loss is 1.3 units per 100 kilograms of body weight. Simply divide 1.3 by 100 and multiply by the individual's body weight in kilos to see where their individual dosing lies. Now, the ceiling dose for females is going to be 2 units per day, split AM and PM. Fasted AM administration being more to promote fat loss and PM administration being favored for muscle mass. We could also see utility if one wanted to use growth hormone post-training to potentially enhance recovery outcomes. There does not seem to be any need to cycle on or off growth hormone. However, there may be a case to pull use in the final week prior to a show to reduce associated water retention. The potential side effects are going to be high doses of growth hormone, increased fasting blood glucose, increased insulin levels, and insulin resistance. This is typically not seen at low doses though. Insulin is known as the storage hormone. It's produced in the pancreas and is used when food is consumed to help transport glucose into the cells for energy. As glucose levels rise, the insulin released from the pancreas stabilizes these levels. Insulin also signals fat cells to take in insulin to be stored triglycerides. When insulin can't get to the receptor on the cells, it means that the blood glucose remains elevated because the body keeps producing more and more insulin, and the beta cells that produce the insulin struggle to keep up with the demand, and the pancreas will eventually burn out and slow down. The body now becomes resistant to the insulin it produces. One big consequence is as blood glucose levels continue to rise, a person could become susceptible to type 2 diabetes. Insulin's effect on protein synthesis is permissive, overmodulating. In other words, insulin alone does not cause protein synthesis. Insulin primes the system, but the amino acids drive the anabolic machinery. Insulin stimulates endothelial-dependent vasodilation via nitric oxide synthase, resulting in nutrient blood flow to the tissue. Insulin also has a permissive effect to optimize nutrient uptake and growth hormone IGF-1 synergies. It increases the growth hormone receptor, reverses IGF-1 desensitization, and stimulates GH to IGF-1 expression. So when do we consider implementing insulin? Insulin would be best served to be implemented primarily in an off-season setting, when food volume and androgen levels are peaking, when we notice increased lethargy, decreased appetite, slow GI motility, decreased pumps in training, and the purpose is to optimize fasting blood glucose levels. Using the safer use model, initial insulin implementation would be long-acting insulin, or Lantus, for relieving beta cell function and as a basal insulin supplement. Fast-acting insulin, so a Humalog or a Novolog, can be implemented around large carbohydrate meals. All efforts should be made to improve the root issue of systemic inflammation and insulin resistance, regardless of whether or not insulin is used. And it would be best to be prioritized in a cyclic fashion based on blood glucose levels. Possible side effects: hypoglycemia is a primary danger when using insulin. Signs of hypoglycemia include cold sweats, lightheaded, irritability, hunger, drowsiness, and dizziness. If you've ever had it, when you're in the gym, the lights just spin and you feel like you're in a daze. If symptoms of hypoglycemia occur, check blood glucose. If less than 70 milligrams per deciliter, consume 15 grams of carbohydrates every 15 minutes until your blood glucose goes above 70 milligrams per deciliter. Carbs should be from simple sources, so like candy, glucose cubes, Rice Krispie treats, all that kind of jazz. Let's to yohimbine. Yohimbe is an evergreen tree from Africa. It has a bark, like all trees do, and in that bark is an active compound called yohimbine. Yohimbine is the part that you guys are concerned about. This is the part of the tree that has those potent properties that I'm going to cover. So yohimbine has been around for a very long time, mainly used as an aphrodisiac and as a natural method of improving blood flow to the penis to help with erectile dysfunction. More recently, it's been promoted as a stubborn fat loss drug. So it helps with libido, erections, and stubborn fat loss, which kind of makes it a miracle drug, right? Well, yohimbine is an alpha-2 receptor antagonist. To understand what that means, we have to understand the central nervous system. The central nervous system can be divided into two separate systems, the somatic nervous system and the autonomic nervous system. The somatic nervous system sends signals from the brain to the muscles and is involved in conscious movement. Now forget that because you don't need to know it. Autonomic nervous system is the one affected by yohimbine. This system sends messages from the brain to the visceral organs like heart, stomach, and intestines, and it is in charge of the unconscious activity that is needed for survival. This autonomic nervous system is divided into sympathetic and parasympathetic. The sympathetic being responsible for the flight or fight response, and the parasympathetic is the one working on the body when it is in a state of zen. So yohimbine affects the sympathetic, the flight or flight response. The sympathetic nervous system releases noradrenaline that attaches onto 4 receptors: alpha-1, alpha-2, beta-1, and beta-2. The alpha-2 receptor is responsible for telling the other receptors to chill the F out so that the body doesn't stay in that flight or fight response. When yohimbine attaches onto this receptor, it blocks it, so the sympathetic nervous system just keeps on going. So heart rate goes up, people experience increased sweating, and become more alert. Yohimbine also releases more adrenaline, and it also acts directly on the fat cells. All of the fat cells have either alpha-2 or beta-2 receptors. Beta-2 tells the fat cells to break down fat for energy, and alpha-2 does the opposite and prevents lipolysis. So alpha-2 can be seen as the stubborn fat loss cell. Yohimbine blocks these, stopping their function, allowing the beta-2 receptors to become more active, and as a result, the body burns more fat. The greater expression of alpha-2 adrenoreceptors on the gynoid adipocytes of females could make them more responsive to the yohimbine deployment. Things to know: peak levels are going to be 30 to 60 minutes after administration and sustained for 3 to 4 hours. You want to take this during a fasting state, increasing the free fatty acid mobilization. In a fed state, this may increase insulin response and insulin resistance. Upregulation of alpha-2 receptor is possible with frequent and chronic dosing. Single daily dosing is less likely to cause upregulation of alpha-2 receptors. 0.2 milligrams per kilogram of body weight is the studied effective dose, and you want to taper up to this dosage. And you want to implement this 6 weeks out from prep for stubborn fat loss. Clenbuterol is the beta-2 receptor agonist, which has actions on skeletal muscle anabolism and adipose tissue lipolysis. If we refer back to the discussion on yohimbine, all of the fat cells have either an alpha-2 or a beta-2 receptor. Beta-2 tells the fat cells to break down fat for energy, so by being an agonist, clenbuterol mimics this action. It also has action on beta-3 receptors, primarily actions in adipose tissue and stimulation increased lipolysis. It has also been used as an anti-asthma medication, with dosing being between 40 micrograms and 80 micrograms per day. Clenbuterol 2 has mTOR activation mechanisms. It controls the anabolic and catabolic signaling of skeletal muscle mass, meaning clenbuterol may help conserve body protein at the expense of fat. A study in humans given 80 micrograms of clenbuterol shows an increase in resting energy expenditure by 21% and fat oxidation by 39%. 80 micrograms has also shown phosphorylation of mTOR increased by 121% and 35% increase in phosphorylation in pKa substrates, which is the family of enzymes dependent on the cyclic AMP and has several functions including regulation of glycogen sugar and lipid metabolism. The half-life is 34 hours. And the dosing starts at 20 micrograms a day, and you titrate that up as needed to 80 micrograms a day. The potential side effects include increased tremors of body and awareness occurs. Although as B2 desensitization occurs, this resolves rather quickly and usually within 18 days. Hypokalemia, which is low potassium levels, muscle cramps, insomnia, sweating, increased blood pressure, and nausea. Now, I'm sure if you're in the bodybuilding realm, you have heard in passing that clenbuterol is bad for your heart. Well, we actually have a study that was done where 7 subjects with heart failure used clenbuterol for 12 weeks, and they started at 120 micrograms per day and titrated up to 700 micrograms per day. They found no significant difference in left ventricular and a diastolic diameter increase. Wall thickness did not change. Left ventricular mass did trend upwards by changes in ventricular data, but not via increase in mass. No changes in right ventricular dysfunction and no changes in aortic valve opening frequency. Conveniently, this study also looks at the markers of skeletal muscle mass and size, which is of particular interest to our cohort. They found that there are no significant increase in both size and strength when using clenbuterol. And although there was an average of 11.8 increase in lean muscle mass, and this was measured by a DEXA, the ratio of lean to fat tissue did not change. There are many other papers that use clenbuterol as part of the recovery protocol for individuals with very poor cardiac health. One study using the half-fill protocol, which is another titration up to 700 micrograms per day, showed a profound improvement in cardiac function. It's safe to assume that clenbuterol used at very low doses over a period of up to 12 weeks in humans with severe cardiac issues either did not worsen or profoundly improve cardiac function. Some bring up that clenbuterol being potentially negative to cardiac health by depleting taurine. This is true, however, the data has little relevance to humans. Firstly, the data has not been shown in humans, and in fact, quite the opposite from what we've seen above, and no adverse effects at very high dose use. Secondly, the doses used in this study were 2 milligrams per kilogram. Running the conversion of rodent to human dosing, that leaves about 800 micrograms per day. Regardless, there does not seem to be a harm in supplementing with 5 grams of taurine a day because it's safe and it's relatively cheap and it's readily available.